So I'll be talking about OCT macula. For want of time, I'll be going a little faster on the text slides. I'll be going a little faster in the text slides. So as we all know, optical coherence tomography or OCT, the basic principle is basically the low coherence light source which is there, which goes to a coupler, gets split and goes to the sample arm, that's the tissue which we want to examine, and then one goes to the reference arm. So when it comes back, it has a small difference or interference. So this interference is detected by the detector and gives the image. So this is the basic principle. That's a Michelson's interferometer principle. So evolution, when you go to see, it was 1971 when we started seeing inside the tissue, and then uh, by this time we have got many other principles, that is time domain, spectral domain, and swept source. The most recent being the swept source, which gives the best resolution until compared to the other ones, which is almost the 5 microns. The speed of acquisition is also more, and the wavelength is 10-50 nanometers. So this is the evolution, and then what are the protocols of scanning? That is the parallel line scans over here, which you can see is a raster scan. Then we have the radial scans, which is in a radial fashion, in a circular fashion, and then we have the 3D scans. That is macular cube or 3D cube kind of a scans. So how do we take OCT scan? We need at least a pupil diameter of 3 millimeters. Select the scanning protocol, keep it straight to the fundus, and then center the fovea or center to the area of interest. Once that is done, you can have a click, and then you get the OCT scans, which can be analyzed for qualitative and quantitatively. So next thing is, how do we interpret? So one is, you need to see if the patient name is proper, age and sex. If it's not the same name, then you might be injecting some other patient. So you need to be sure that you are having the proper name and the same person. Identifying the eye. So basically, the nasal side, we have the PMB nerve fiber layer, which is a little more thicker, which I'll be showing you. And then signal strength should be maximum, and direction of the scans also should be noted. So going for the normal OCT, like I said, first we need to know what are the hyperreflective bands. As you can see, all these are noted here: hyperreflective zones, hyporeflective and hyporeflective zones, and choroidoscleral junctions. So these are all the things which fall under it. And then the other classification which you need to know is reduced reflectivity and increased reflectivity. So these are all the things which you see in the OCTs. So once you know about this, it will be easier when you see a scan. So another thing is, the older versions you should get a false coloring code. So high reflectivity you should get red, moderate high you should give green or yellow, and the hyper-reflective is to be blue or black. So when you see another false colored OCT, you should know which one is what. So here you can see this is the left eye, because the nasal fibers are coming on this side. Okay, so this is what how you identify which eye. So this area you have to see, and then these are all the hyper reflective. This is hypo, this is hyper, this is hypo, this is hyper. So all of these you can actually understand by taking the normal retinal fiber anatomy. These horizontal fiber layers, horizontal tissue, give a hyper-reflective, rather than these cells which are radially placed, that will give you hypo-reflective scans. And then we have this ISOS junction, which was previously named under the international nomenclature. This is basically the inner segment and outer segment of the photoreceptor layer, which is also being called as the ellipsoid zone. The ellipsoid zone has a hyperreflective layer, mainly has the mitochondria. What is a normal line scan of OCT, which has a normal vitreoretinal interface, normal retinal morphology, normal foveal contour, and normal inter photoreceptor layer, that is ISO junction or ellipsoid junction. These area are hyporeflective areas. These are moderately hyperreflective. These are highly hyperreflective, that is hyperreflective. And then we have areas of after shadowing, because it is a few of the lesions take up the hyperreflective and causes a after shadow. And then hypertransmission, wherever the retina is thin, there is higher light going to the choroid, so then we get a hypertransmission. So these things you need to know when you interpret a OCT. So where are the lesions which you can tell? That is, one is in the pre-retinal, one is the epiretinal, intraretinal and subretinal. And in subretinal you have the subneurosensory retinal and sub-RP level. So whenever you describe a lesion, you can put into all these things. So what are the ones which comes in the pre-retinal spaces? Over here you can see this is the pre-retinal space. You have an incomplete PVD over here, right? And then we have vitreous cells. In this image you can see vitreous cells over here, hyperreflective dot kind of a lesion. That's all vitreous cells over here. And it is very important to even differentiate these cells by with the vitreous hemorrhage sometimes over here, like how you can see in this DR case. Then we have the vitreoretinal interface. One of these are vitreomacular traction and adhesions, like you can see here. Focal VMTs are the ones less than 1500 microns. Broad VMTs are more than 1500, like over here. And then you can see this one. This is the posterior cortical vitreous, which has a traction towards the macular foveal area. Here you can see there are multiple vitreous planes. So these are all vitreous sizes which we can see in mostly diabetic cases. Then we have epiretinal membranes. So these are the classification for epiretinal membrane. Over here you can see a hyperreflective line kind of a lesion. This is a ERM, epiretinal membrane, which is being seen over here. And when it increases, when the epiretinal membrane starts pulling the foveal area, you can get macular pseudo holes. Like over here, this is a pseudo hole. It's not a full thickness macular hole. And then when there are intraretinal spaces like over here, you can you name it as a lamellar macular hole. And then we come to the full thickness macular hole. In the first few stages, it is more of a vitreomacular traction, which then develops to an operculum. Yeah. Operculum. There are other lesions of intraretinal, subretinal, and outer retinal, like diabetes macular edema. You can see over here, these are a few of the biomarkers. Intraretinal cyst, this is the bridging retinal process. And then you have central subfield retinal thickness. So these are all the biomarkers you need to see in a diabetic macular edema case. And then we have drill, disorganization of retinal inner layers, ELM and EZ disruption. It's a pearl necklace sign, which is seen in a chronic case. Intraretinal hyperreflective material. These are also indicative of at least 6 months old diabetic macular edema, which has poor prognosis. Then we have a hard exudates with the back shadowing. Then taut posterior hyaloid. I think it's time up for the next session, so probably I'll stop here. Thank you.